All right. Everybody, welcome back. We will continue here onwards with our melanoma symposium this morning. And I will introduce Dr. Rothermel. He's an associate professor in the Department of Surgery and chair of chief of section of soft tissue and GI surgery. Me and Dr. Rothermel almost started our careers together at university hospitals. This is my first job. I believe this is your first job as well. Yeah. And we together, when we started, we had one clinical trial. Now we have almost over 18 clinical trials, and we have recruited nearly 150 patients, more than 150 patients in the last 5 years to clinical trials with lots of success. And but Dr. Rothermel has been instrumental in developing the surgical oncology program in melanoma, and he was the one who actually brought in the concept of sentinel lymph node biopsy. He's going to talk about that. So without any further ado, I'll have Dr. Rothermel take the stage, please.
Okay, thank you for the opportunity. I appreciate the introduction, Ankit. It is wild to hear these talks on the progress that has been made in treatment of advanced melanoma. It begs the question of why not treat everybody? Why not just everybody get a little bit of immunotherapy? And the reality is that we don't need that. Thank you. All right. I have one disclosure that doesn't actually have any bearing with this talk. What I am going to try to educate you on is what we do as surgeons when patients come to us and what the surgical approach is for melanoma. Then what the benefits and risks of immunotherapy are for surgery patients. And finally, what is the harmony of surgery and immunotherapy? Most patients with melanoma present to me without clinical evidence of that melanoma has spread. So what that means is you come in with a biopsy site that has proven that you had a melanoma on the skin, but I can't find on my clinical examination any evidence of lumps, bumps, lymph nodes, or other things that represent spread of melanoma. And so when I think about this, there are perspectives on what I should offer patients. Most patients are getting a wide excision for their primary melanoma. Not really most patients, everybody gets a wide excision. And the purpose of this is to decrease local recurrence and get the melanoma out of your life. But about 85% of people coming into my clinic will have localized disease. So the lesion on the skin. And in most people, cure is possible with surgery alone. So of those, most melanomas are thin or very thin, less than a millimeter in invasive depth. And that means that we really should consider what do we need to offer these patients. Those thin and very thin melanomas have a low chance of recurrence. So what do we offer if they have a higher chance? Well, we offer a sentinel lymph node biopsy. If I can't feel evidence of melanoma in a lymph node, it doesn't mean that it hasn't traveled. It means that if it has traveled microscopically. We need to take the first draining lymph node out to send it to the pathologist and have them do their due diligence, cutting up that lymph node in great detail and meticulously proving that there's no evidence of melanoma in it. Now, so the very low risk patients that come in with a thin melanoma or very thin, wide excision may be appropriate, but for those with higher risk or higher chance that melanoma may be in lymph nodes, we use a sentinel lymph node biopsy. And this answers the question of has melanoma spread and do we need extra treatment? Now, how do we decide what to offer the people that come in? Well, if you have had melanoma or if you've had a family member who's had melanoma, you have a pathology report that comes to you with this synoptic report. And that reports on dozens of features of that primary melanoma. Now, it is in many ways written in code. The things that really inform me of what I should do are the Breslow depth, so that's the thickness of the melanoma, and then high risk features. And I apologize about how this is coming out with my size here, but high risk features of the melanoma, things like ulceration, things like lymphovascular invasion or mitoses. Mitoses is when the pathologist looks at the slide and sees evidence of melanoma cells dividing. They count the number of times they see that and they report it. So we take all that information and we decide what to offer as a result. And the goal of our procedure is, number one, trying to cure melanoma. And like I said just a little bit ago, cure is the goal, but cure is not something that we can prove. And so we aim for it. We know that we can achieve it, and that we take it with caution, knowing that melanoma can be quite sinister. So the additional goal of surgery is staging as melanoma travel. And we can also, this blue line is supposed to be under regional disease control, not through it, but we can also decrease the chance that it shows up in a regional lymph node basin by doing surgery. And then there are other things for more advanced melanoma, surgical consolidation. So after you get treatment, removing anything that remains, or even palliation. If there are tumors that are causing pain, we can be involved as well. But I'm going to focus on the top three, and I'm going to show you some graphs here. These graphs show the likelihood of dying from melanoma based on the various stages that people start with. So each category or line represents the survival based on the tumor thickness and whether or not high-risk features are present. This graph in particular is showing the early stages of melanoma, stage 1 and stage 2, and these are patients that do not have lymph nodes involved. And so when we look at these, in this, we see a dotted blue line that's arbitrarily set at 80%. I put this up here because some of the other graphs will have 80% at a different level, and it's hard to look at that visually and perceive the difference. But down in this corner, we're starting at a 50% likelihood of melanoma-specific survival, and other graphs start at 0. So it's confusing. Nonetheless, what I want you to see here is that these blue lines show the thinner melanomas. And these are the patients with thin melanomas with or without high-risk features. And most patients do very well. Patients with the thinnest melanomas without high-risk features, 98% of them will be alive at 10 years and not have had consequences of that melanoma. So these are patients that we commonly do not recommend for sentinel lymph node biopsy because they do well regardless. We don't need to do extra surgery for patients that do so well without and have such a low likelihood of lymph nodes being involved. But that 2%, so this 1A group, right up here, 2% of patients within 10 years will die from melanoma. That is not a lot, but that is still very important to us. And that, again, is why we don't trust the disease, and we need you plugged in with your dermatologist, and we need to counsel you and educate patients to make sure that you just know what to look for, how to be in touch with your treatment team, and to know that we're always available. So the orange line, these are patients with intermediate thick tumors. And this shows that 90% of people will survive melanoma at 10 years. So still a very high rate. Now, as we go to what we call the high risk stage 2 category, These are patients without lymph nodes involved, but have thicker tumors or intermediate and high-risk features. And these patients start to show that the risk of something coming back and shortening a life is significantly higher. And I want you to think about these because as we look at the next slide, I want to emphasize that in comparison to the patients with node-positive disease. So most people can be cured with surgery alone. However, if lymph nodes are involved, the prognosis tends to be worse. This is why we check lymph nodes, and often we are using sentinel lymph node biopsy for people, because if you have the thin melanoma, but your nodes are positive, it's important. If you have a thicker melanoma and your nodes are positive, it's certainly important because it increases that chance that melanoma will come back and that there can be a worse prognosis. These stages, or these lines on the graph here, break down the stage 3 patients by stage 3A, B, C, and D, with each one becoming more severe. And that's broken down, or we categorize those by the primary tumor features and the number of lymph nodes involved. When lymph nodes are involved, then the recurrence rates are high. But why is that? I want you to think about this. When you think about melanoma starting in the skin, if those cells in the skin evolve the ability to travel, survive the trip through the lymphatic vessels into the lymph nodes, then they've already changed. Something has changed in the biology of that cell that allows it to be able to survive and evade the immune system. And in those cases, we know that it may have even gained the ability to spread beyond the lymph nodes. That's why this is an important detail. So, of all the patients coming into my clinic, about 20 to 25% will have a positive sentinel lymph node. Higher if the tumor characteristics are worse when we start, and lower if they are if they're thinner and without high-risk features. So the last thing I want you to see here, though, is this. This is stage 3A patients, and we've got our arbitrary 80% line here. Stage 3A patients with thin melanomas and a small number of lymph nodes involved honestly tend to do very well without any additional therapy. And this is important because of what the therapies can do. Without that additional therapy, we're looking at 10-year survival of 88%. Most patients do very well. But what about patients with that come in with bulky disease? And this is about 8% of patients that show up in the office with a biopsy on the skin, and we do an exam, and I say, "Oh, I feel something." We do our imaging. We find that what we feel represents melanoma. And what do we do for them? Well, these don't get a sentinel lymph node biopsy. We do complete lymph node dissections. If a tumor has grown in an area like the armpit or the groin or elsewhere, large enough that I can feel it, then it's more likely that it's in more lymph nodes that I might not be able to feel. So additional lymph nodes in that area. And so a complete lymph node dissection is part of my surgical offering to these patients. But how do we decrease the risk? No matter what surgery we do, how do we decrease the risk of recurrent melanoma? Well, we have thought about this historically in a lot of ways, and we used to do more surgery for every patient that had a positive sentinel node. So microscopic evidence of melanoma in a lymph node, we reflexively go back to the OR, take out all the lymph nodes. And thank God, we had a very large international clinical trial that thousands of patients participated in that showed us that if we go immediately to the OR and do that complete lymph node dissection, or if we wait and do active surveillance, watch very closely to see if anything comes back, and only do that operation if something recurs, we found that the outcomes are not different for those people that have lymph nodes involved. So I don't need to rush back to the OR. In fact, only 20 to 30% of patients will ever need that surgery after that initial positive sentinel lymph node. And 70 to 80% are now spared the more aggressive surgery. So it's a wonderful change in our surgical practice, a de-escalation that matters to patients. So we don't offer more surgery because it doesn't decrease the chance of recurrence in a meaningful way. Radiation. Radiation is not significantly effective for controlling melanoma recurrences. We use it on occasion for more advanced disease when other therapies have been exhausted, but radiation is not a standard. Cytotoxic chemotherapy. So as Dr. Shang had mentioned, it has a role for advanced disease, but it is not our standard approach, and it does not decrease the chance of any recurrence after surgery. So what do we use? Well, immunotherapy and targeted therapies. Targeted therapies are how I'm going to talk about BRAF and MEK inhibitors that Dr. Schwartz had mentioned. So the standard of care, the standard approach, though, that we will offer to most patients is immunotherapy. And this is either a single agent, nivolumab or pembrolizumab after surgery. And how did we get there? Well, this is one of the studies that looks at using pembrolizumab, so Keytruda, after surgery versus a placebo. And what you can see here, this is 7 years of survival where patients that got the pembrolizumab have a higher chance that they're living without melanoma. And that persists. And what it comes down to is the select patients in this trial had about a 15 to 20% fewer recurrences over 7 years, and we expect this to go beyond. So that's important. And it's great. It's great to think about that as is this going to be beneficial for me, and should I be jumping into the therapy? Well, when we look at this graph, and this is the same study, just shortened at 2 years, just for the sake of diagramming, there's a proportion of patients that are not going to respond to our therapy. So even though we give the Keytruda, these patients may not respond to it, and they will still have recurrences. There's a proportion of patients that aren't going to have a recurrence regardless of the therapy. And then there's this meaningful 15 to 20% that will actually benefit. So if that's the relative benefit, what about the toxicities? What about the risks? The numbers for this vary in certain clinical trials, but when looking at different reviews that kind of look at the ranges of toxicities, toxicity rates can be about 60 to 70%. Now, most of those toxicities, though, are low grade, manageable, things like fatigue and other things that we can get you through. Serious toxicities are what we think about. These are things that can be life limiting, can require chronic drug management like steroids, or can cause you to come off the drug or the immunotherapy because it can be very harsh. And that happens in about 15 to 20% of people. So when we think about how do we decide, this one off, sorry. How do we decide who should get it? The severity of the disease matters. So if you're looking at higher stages of stage 3 disease, stage A, B, C, and D, the severity is higher as you go down that line. The relative benefit is greater, though, for each one of these. So if your risk of recurrence is significantly high, then maybe it's worth the benefit of that therapy. Whereas for toxicities, it remains pretty similar across these stages. And so when you are looking at the stage 3A patients, where the relative benefit is small because most patients do well anyway, but the toxicity rates are potentially substantial, then we don't always offer immunotherapy. In fact, when we ask the question who should get it, we tend to let me couch this. Every one of these situations, these patient scenarios, is a discussion between you and your medical oncologist. We may give you all the data that we're talking about here and tell you that we think there's a benefit. But every one of them is a very individualized, shared decision that you need to make with your provider. But we tend to see that the benefit that we can achieve for stage 3B, C, and D often makes sense, especially for the stage 3, C, and D. Whereas for stage 3A, even though the therapies are approved, the relative benefit versus the risks don't tend to push us in that direction. Now, how about for the early stage, the lymph node negative ones? We don't offer it for patients that have early melanoma. We know most are cured with surgery. For the stage 2B patients, we'll consider it. And then for stage 2C, lymph nodes are negative, but we would still recommend this therapy because these are high-risk primary tumors. So for clinically evident stage 3 melanoma, though, the patients that come in with bulky lymph nodes or other tumors that are resectable, but we know that there's tumor there, we have moved toward a neoadjuvant approach. So Dr. Shang talked about this. This is very important, and this is very recent that we changed our practice. But because the immune system can be trained against a tumor like this, we know giving the immunotherapy while the tumor is in place is actually better for people. In this picture, we see that the neoadjuvant immunotherapy was given, the tumor shrank, and when I went back and took all these lymph nodes out, there was 0 viable tumor. Even though there was a mass still there, it was all a shell. And that's a wonderful thing, and that gets to Dr. Schwartz's point that at some point, we are going to minimize our surgery even more because we want to minimize the morbidity of what we put patients through. These slides are way off, but this is the graph from the SWOG 1801 clinical trial, where we compared giving pembrolizumab up front for 3 doses and then do surgery and then complete the year of pembrolizumab versus doing surgery and doing the adjuvant therapy, which is our standard of care. And we found that the likelihood of having a recurrence is lower if we do the upfront immunotherapy. So this was a phase 2 trial. And then the more definitive trial that ended up changing our practice for everybody was the NADINA trial. This used Ipi/Nivo, 2 doses up front, surgery, and then looking at, we did surgery for everybody. Looking at the difference in recurrences, it's actually striking. The benefit that we get from this, specifically and especially for people that have a major response to the immunotherapy, is very telling. And what's going to come from this approach is that maybe we don't need to do therapy beyond. If somebody gets a great response from our immunotherapy that we see by taking the tumor out, and we see that there's been a major response, maybe we don't need more immunotherapy. Maybe we can lessen the toxicity of our treatments that way. Lots will continue, and I think Dr. Mengele will allude to some of that. But here it is. So, do we add immunotherapy for everybody? The answer is no. Who do we tend to consider it for or recommend it for? Well, it's these high-risk patients. And stage 2 patients, even without lymph nodes, can be considered for this. But they have to be the high-risk stage 2 patients. But there are also special circumstances. The stage 3 patients with a larger nodal deposit, greater than 1 millimeter, we weigh the risks and the benefits in that discussion. Then those clinically stage 3 patients, we treat up front. So this is how we approach our consideration for these immunotherapies. And what we are finding is that the harmony that we achieve is decreased recurrence rates, it's hope for better survival, and yet we use it in select patients, understanding that we do not need this for everybody. Melanoma can still be cured with our standard approach for the majority of people with early stage disease. And here's our melanoma disease team. We meet every Monday in our tumor board, and we talk about people with melanoma. We are blessed to have specialists in every discipline, and these conversations get very interesting because we want to make sure that we are offering the standard of care for everybody, that we get it right. And then we're offering clinical trials for anybody that might be appropriate for them. And so these discussions are great. We learn a lot by this practice. And if you are one of the people that we have treated, you have been discussed. So thank you. Appreciate your time.